For week 2 of NUR 200, we will examine the concept of fluid and electrolyte balance with the specific disease processes of diabetes insipidus and syndrome of inappropriate antidiuretic hormone as our exemplars. We will have a quick review of fluid balance and then a review of sodium, hyper, and hyponatremia. So why is fluid balance important? Kind of a rhetorical question. Well, because when the scale tips too much towards one way or the other, result creates more physiologic problems for a patient. Fluid volume excess, especially in the vascular system, can result in hypertension, congestive heart failure, pulmonary edema, or peripheral edema. A deficiency of fluid or depletion of intravascular fluid volume can result in dehydration in some or all of your compartments, shock, and alterations to some of your organs, especially your kidneys. So basic physiology. There's a continuous exchange of fluids across the membrane that separates the intracellular, interstitial, and vascular fluid compartments. The majority of the fluid of the body consists of water, which is carrying nutrients, electrolytes, and minerals. Water percentages will vary according to age, but water consists of 60% of the body weight in a middle-aged adult. In children, this percentage becomes higher. Electrolytes, glucose, and minerals will usually pass freely through the cell membranes, while larger molecules such as protein and red blood cells are less able to cross membranous boundaries. This is why, if you see a urinalysis with protein or red blood cells in it, it's indicative of problems with the glomerular membrane and is indicative of kidney problems. This visual demonstrates the concept that the body consists of 3 separate and distinct compartments, or tanks, as I like to call them. You can see here that the intracellular compartment comprises 40% of body weight, containing approximately 25 liters of water. Interstitial fluid and plasma together comprise the remaining 20% of body weight that is composed of fluid, with 12 liters in the interstitial fluid and 3 liters contained in plasma. As demonstrated by the graphic, there's a communication of fluid between each compartment, but each component must be considered individually. For example, it is possible to be intravascularly volume depleted while you have fluid overloaded in the interstitial compartments. Let's examine the concept of osmolality, which is dependent upon the number of dissolved particles or solutes in 1 liter or 1 kilogram of water. More often than not, osmolality is determined by the amounts of glucose, sodium, or urea molecules contained in the plasma. A normal serum osmolality is 275 to 295 milliosmoles per kilogram. This is not a lab that I've required you to know, but it might be one that's good to be familiar with, especially as you move forward into future classes. An increase or decrease in osmolality can cause water to move between compartments in an attempt to bring the osmolality back to normal levels. For example, think about a patient with diabetes. As the amount of glucose molecules circulating in the vascular component increases, the osmolality or thickness of the blood increases. This causes a pull of fluid from the interstitial compartment, eventually causing a fluid overload in the vascular system, which results in the polyuria that is characteristic for new onset type 1 diabetes and also for patients that are going into DKA or HHS. Fluid balance is achieved through multiple complex mechanisms. Ideally, an adult should take about 2,500 milliliters of water in, which should equal the amount of water out. So if you're not doing that, you should get some water right now and have a drink. Thirst is one of the most important regulators of fluid intake, although often by the time that thirst becomes apparent, the patient may have already had significant fluid volume depletion. The primary regulator of fluid output is the kidney. They're little divas. They want everything. They want oxygen and they want pressure. When they don't get what they want, they pitch a fit and cause physiologic changes. We discussed the role of erythropoietin in the exemplar of anemia. Now let's examine the kidney with respect to fluid volume management. In the presence of a decreased glomerular filtration rate, the kidney will secrete renin, which in turn will stimulate the liver to release angiotensin 1. The lungs release angiotensin-converting enzyme, which will cause a conversion from angiotensin 1 to angiotensin 2, resulting in vasoconstriction and aldosterone release. The end result being that the kidney will retain sodium and water while secreting potassium. The posterior pituitary gland releases antidiuretic hormone, which is secreted in response to changes in osmolality, with the end result being increased renal absorption of water. Much like many disorders, fluid balance disorders can be characterized as being too little or too much. A fluid balance deficit has the potential to cause dehydration or shock and is treated by replacing what is missing. Fluid volume excess is treated with pharmacologic agents which cause the body to release excess fluid. Let's talk about the nursing implications with fluid volume assessment. Your pre-class assignment is going to examine signs of dehydration versus signs of overhydration. You should be familiar with these physical assessment findings. Vital signs can result in changes due to fluid balance problems. Intake and output become an integral daily assessment of fluid balance, so don't ever underestimate the intake and output. And the daily weight is the single most important nursing assessment when examining fluid balance on a day-to-day basis. Let's switch gears a little bit and talk about sodium. Sodium is a major extracellular electrolyte essential for maintaining osmolality and water balance. Water will move towards an area with greater osmolality. Think about water and sodium like peanut butter and jelly. They're just better when they go together. Increases in both water and sodium are going to increase blood volume and therefore blood pressure. Therefore, that's the reason why we have low sodium diets for patients with hypertension. It's going to decrease blood volume and hopefully decrease the amount of the patient's blood pressure. Regulation of sodium levels is regulated by the kidneys and by the hormone aldosterone. As previously stated, aldosterone secretion will cause sodium retention and potassium excretion by the kidneys. Since water follows sodium, water is retained as well. When aldosterone is inhibited, sodium and water are retained and potassium is excreted. Okay, time for a little bit of pharmacology. Aldactone, which is also known as spironolactone, is a pharmacologic agent which blocks the action of aldosterone. In this slide, we simply have a visual representation of the relationship between the kidneys and sodium and potassium balance. You can see where sodium and potassium can go in and out of the plasma, regulated by the adrenal gland and aldosterone secretion, ultimately looking at how the kidneys will hold on to or excrete sodium and potassium. Hypernatremia is defined as a serum sodium level of 145 milliequivalents per liter or greater. Sodium will accumulate in the body due to decreased excretion by the kidneys, a high net water loss, for example with watery diarrhea, fever, or burns, and inadequate water intake. High doses of glucocorticoids or corticosteroids or estrogens can cause a hypernatremia, and excessive salt intake through diet can also cause hypernatremia. And there's a mnemonic here to the right that gives you a way to remember causes of a high serum sodium level. The physiology of hypernatremia are that elevated sodium is going to increase the osmolality of plasma and draw fluid from the interstitial spaces in cells, causing a cellular dehydration. Now, when you think of sodium, I want you to think about neurologic problems, but also think about thirst. Thirst is going to be one of your signs that you need to look at. Other than that, most of your signs and symptoms of hypo and hypernatremia are going to manifest as neurological difficulties, as you can see here. Treating hypernatremia is by reducing dietary sodium, as well as replacing IV fluids if you're dry, or giving diuretics if you're wet. Hyponatremia is when your serum sodium level drops below 135 milliequivalents per liter. It caused by an excessive dilution of plasma, caused by excessive ADH secretion, too much hypotonic IV solution, or water intoxication, which is an obsessive consumption of water without anything else being consumed liquid-wise. It can be caused by an increased sodium loss due to vomiting, diarrhea, GI suctioning, or diuretic use, and it also could be caused by excessive sweating or advanced kidney disease. Early symptoms of hyponatremia are nausea and vomiting, as well as abdominal cramping, and then your late signs are those neurologic signs once again. So when you look at hypo and hypernatremia, the later signs are similar, and so kind of easier to remember that way. Treating hyponatremia, well, when you're missing it, you give it back. So you can treat with oral sodium chloride or IV fluids containing salt. If it's an excessive dilution thing, you also can give loop diuretics to cause an isotonic diuresis. So we're going to review DI and SIADH in class. The culprit in the physiology of DI and SIADH is antidiuretic hormone. I want you to think about what we talked about. What is the job? Okay, because when you look at these things, you have to look at normal function and then if you have too much and too little. A normal functioning is that when your serum osmolality increases, the body will release antidiuretic hormone to cause a renal retention of sodium or renal retention of water to decrease your serum osmo and reduce the risk of dehydration. Both disorders are classified as endocrine disorders, but their effects are fluid and electrolyte related. The posterior pituitary is responsible for the secretion of antidiuretic hormone, and you think about things being too much or too little. So with diabetes insipidus, it's dry. Think about D is dry. It's a deficiency of ADH, and I want you to think about these questions. If you're not holding on to water, where's it going? What happens when the water leaves and the sodium doesn't? There are some risk factors for diabetes insipidus, one of the biggest ones being head injury. It also can be a pituitary tumor or someone who is post-operative from brain surgery or craniotomy. So with DI, think about dehydration. With DI treatment, you always want to look at the problem. If the initial problem is a head injury, you may have to work around that until the body heals. And you're going to replace fluid volume, and you also can give back antidiuretic hormone in the form of DDAVP, also known as desmopressin or vasopressin. SIADH, syndrome of inappropriate antidiuretic hormone, S equals soggy, and it's an excessive production of antidiuretic hormone. So if you have too much of the hormone that holds on to water, think about the physiologic changes. What's going to happen to your osmolality? What's going to happen to your daily weight? What's going to happen to your blood pressure, urine output, all of those things. So think about the implications of that. As far as risk factors, I always have heard oncology patients tend to be at a higher risk for developing SIADH, especially patients with small cell lung cancer, because those lung cancers causes an ectopic release of ADH. So think about what happens to your serum sodium levels when you add more water to the tank. Okay, we'll talk a little bit more about this in class. Treatment of SIADH is going to be to decrease the amount of fluid that's going in. Treat it like fluid overload and think about how you're going to assess that. Diuretics and also dimeclocycline, which we'll talk about in class. Neurologic status is going to become an important assessment as it relates to the treatment of SIADH. This concludes your PowerPoint for class number 2 for NUR 200. For your pre-class assignment, please complete the side-by-side comparison of dehydration versus fluid overload, as it will lay the groundwork for class. Thank you very much.